Hey sir, can you tell me what's going on?
I just feel a little bit dizzy right now.
Okay, well I'm gonna go ahead and have you sit up. Do you think you can do that?
Yeah.
Okay, all right. So I'm gonna
I feel dizzy.
Yeah, well I'm gonna check your balance. So what I'd like you to do is try to stand up for me.
Okay.
All right, and then can you just take a few steps forward? Good, are you able to turn?
Yep.
Good, all right, so we're turning okay, walking okay, all right, and then can you kind of put your back facing this way? All right, so I'm gonna have you stand straight. And then I want you to, without touching anything or leaning onto anything, I want you just to stand here and close your eyes. I just wanna make sure you're standing still and that we're not swaying around. Okay, so we're not, and that's good. You can open your eyes. And then what I'm gonna have you do is just sit up here on the table. All right, and then do you think you can take this heel and run it up and down this leg? Good, can you do that with the other leg? Perfect. Okay. And then can you take like one of your pointer fingers and touch your nose and then touch my finger and then touch your nose again and touch my finger. Okay. And then can you try it with this hand? Good. Good. All right. So we're not struggling to get to my finger and we're not going past my finger. So that's a normal exam.
Yes.
Okay. So the portions of that exam when we're measuring balance, the things that we want to do is that the patient can first sit up, if they can sit up easily on the bed without rocking back and forth, and that is one sign to say that their balance or proprioception is intact. To further test that, we had the patient stand up and walk forward and backward, and they're not leaning to one side or the other, which is a good sign as well, making me think this is less likely a stroke and more likely a peripheral cause of this patient's chief complaint of dizziness. When we sat them on the chair, they were able to do a heel to shin movement, and both of those were intact and normal, which also helps us strengthen our case. And the finger to nose test was normal with no overshooting, which in a stroke patient, you would have overextension of the finger missing the overall target. So all of this normal exam would make me less likely to think that this patient is suffering from a stroke. And we can exhibit some abnormal findings. If we had Dr. Osmani sit up, and as he's sitting up, he's starting to fall back or away from side to side and can't hold himself without being able to steady, then that makes me think that this is a little bit more of a central cause of his symptoms and could be more likely to a cerebellar stroke.
Checking. I always think it's important to actually check pupils too, because a lot of times we've got like hemorrhagic strokes and things. Mm-hmm. So pupils, extraocular movement, and then nystagmus, which typically like you can see whenever they're looking side to side. Okay. Yeah. All right.
And then what's helpful also with strokes that usually involve the dominant hemisphere of the brain, you'll have what they were describing as hem neglect. What I'll do is I'll start my exam on one side, and then I'll walk around to the other side. If they grossly neglect me on one side or another, that gives me a good suspicion that they probably have something going on that's causing them to avoid looking to one side. And they'll generally just look over to one side and they'll almost ignore you completely if you're on the opposite side.
Mm-hmm. So you mean like you physically will walk over, and then if they don't start to turn to look at you?
Yeah, and then I'll say, look at me over here, and then they just don't.
So this is our eye exam. So what I'm going to start to do is just check pupils. So if you've got a light on you or a phone light, I'll just use that. And you just want to make sure that the pupils are both round and reactive. Typically they want to be equal, or they should be equal. If one pupil is significantly larger than the other or not reactive, you're concerned for some sort of central cause. And then what I'll typically do is have the patient follow my finger, and so I go in an H motion. So can you just look at my finger? All right, so follow my finger and keep your head still. You're just making sure that they can look to the side on each side, look up and look down. And then we did that well. The other thing too is if you're concerned about hemi neglect, you can make sure that if you're standing on one side of the patient that they're looking at you, and then you can go over to the other side of the patient and they should be able to look at you and move their eyes to focus back on you. And even then, let's see, what things should I talk about? So obviously we want to make sure like when I do my quick exam of a patient, I always ask them to smile for me, show me their teeth. I want to make sure that it is like equal and we're not drooping on one side. I will also have them raise their eyebrows, and because you want to make sure that there's not like a droop on that side. The other thing too is I'll have them close their eyes real tight. You want to puff your cheeks out. Do you do all that, or what do you like
Generally,
to do?
what I do is I do sensation, so I'll check
You have them close their eyes
this
and check.
area, this
Yeah.
area, this area. If they can feel it grossly, then I
Yeah.
assume that they have normal sensation.
Sure.
If they can't, then it makes me worry about a stroke.
Yeah.
Then I'll go in for the eye exam. Then I'll do, like you said, lift up the eyes, smile, shrug up the shoulders.
Yeah. Okay. All right, so this is the facial exam portion. So, all right, so I'm gonna have you close your eyes for me, and I'm just gonna check your sensation. So you're gonna wanna have the patient's eyes closed, and then I'm gonna be kind of just touching here. Can you tell me where you feel me touching?
Both sides.
Both sides, and where is it?
On my forehead.
Okay, and then what about here?
Both sides on my cheek.
Okay, and then you can go ahead and open your eyes. Can you raise your eyebrows real high for me? Good. All right, can you shut your eyes real tight? Good. Okay, you can open your eyes now. Are you able to smile real big and show me your teeth? Good. Okay, and then can you puff your cheeks out? Good. All right, can you stick your tongue out now? Perfect. So our tongue is straight, and then from there, basically, if you are having any sort of facial droop, but you're also unable to raise your eyebrows, that is forehead, and it involves the forehead. So you usually think of Bell's palsy in those situations. Usually stroke, so you're gonna spare the forehead, so you'll just have facial droop, basically from like here down. And so it's usually just a droop like along like the mouth.
Yeah.
And sometimes what they'll do is they'll literally, so our stroke team will literally hold it and then just see, and then you just it falls, and you're like, oh, okay. So,
Yeah. I normally have the patient, I'll have them extend, close their eyes for 5 seconds, and then count down to 5, 4, 3, 2, 1.
okay, so I'll do it that way. Okay. All right, so this is our upper extremity exam. So I'm gonna have you close your eyes. I'm gonna have you put your arms out, and I'm gonna help kind of hold them like this, all right? And then we're gonna keep them up like that. You're gonna keep it there for 5 seconds. 1, 2, 3, 4, 5. So this is a normal exam. Our arms are not drifting down. This arm, when I put it up, it doesn't just automatically fall down. So this exam itself is a normal exam, all right? And then I will typically check their sensation. So I will also kind of have them close their eyes, and then I'm going to touch both sides or one side. It just depends, and just ask, do you feel you feel both sides? Does it feel the same or different?
Feels the same.
Okay. Sometimes patients will say one side feels like duller, or it doesn't feel right, or it feels different, and that makes you more concerned for a stroke. And then can you squeeze my fingers? Good. And you just check that their strength is normal on both sides. So for your speech assessment, just first talking to the patient, you can hopefully maybe get some info from that. So, hey sir, can you tell me your name?
Javid.
Okay. Can you say today is a sunny day in Lexington?
Today is a sunny day in Lexington.
Okay. And so you want to assess if speech is slurred. Are you able to kind of exhibit some slurred speech, or?
The sun is shining in Lexington.
Perfect. Okay. And then there's also expressive aphasia, which is typically what you think of as word salad. So patients you ask them a question, and then they'll kind of say things that don't really make sense, and and then I don't know if you're able to exhibit it.
Doobie car driving Monday, Sunday.
Yeah. Perfect. So.
Yes. So there's a difference between
Yeah.
aphasia and dysarthria, right? So dysarthria is mumbled speech. So the patient knows what they want to say and they're trying to say it, they just can't get the words out fluently to where you can't understand them. Aphasia is a little bit more so of they can't speak, right? And so there's a couple different types of aphasia. One of them is that they really don't know what they're saying at all. They think that they're making sense to you, but the words are nonsensical. When you ask them a question and they start talking about something else completely. And then there's another type of aphasia that is more of broken type speech, of where they can't get the words out. They have like these word finding difficulties to where you ask them a question and they know what they want to say, but they physically cannot say it. And so that is more of an aphasia. So dysarthria would be slurred speech. Aphasia would be the inability to speak.
So the next thing we're going to talk about is the time frame of the patient's symptoms and when they were last known well. So the biggest thing is figuring out when the patient was their normal self before any sort of symptoms. If the patient can't tell you that, so if they can't say that they, went to bed at 10 last night and they were completely normal, then you would try to get a hold of a family member, someone who's seen them, to verify what was the last time that they were seen acting normal and had no deficits. It's really helpful because when you get to the hospital, it determines what kind of interventions they can get. So in cases where the patient wakes up and they automatically have symptoms, you have to think about what time do they go to sleep. That would, if they were completely normal at that time, that would be their last known well. If they woke up, they were fine throughout the day, and then at 2 p.m. in the afternoon, they started having symptoms, you would say 2 p.m. is their last known well.